Hello everyone, and welcome to today's Network Mind Out webinar. My name is Sally Morris. I'm the National Mind Out Project Coordinator for Mind Out with the National LGBTI Health Alliance. At the beginning of our webinars, I'd just like to double check that people can see and hear us okay. So if you can see and hear me okay, there's a text box on the lower left-hand side of your screen. Can people just type a little message there to let us know that our audio and visual is working okay? All okay, excellent. Okay, wonderful, thank you. If anyone does have any problems throughout today's webinar, you can type a little message there, which let us know how you're going. So today, again, before we begin our webinars, we like to acknowledge the traditional owners on the land of which we're gathering today. And we have people from all across Australia who are tuning in for this webinar. So we're all meeting on lots of different country today. Okay, Rod is not hearing anything. Just maybe double check your volume. Your volume button is up. Sorry, I just lost the word for that. So just double check that. Today's webinar, and you probably can't hear me say that because you can't hear anything. We also like to acknowledge the LGBTI elders and people who have worked tirelessly over years to support our community to get to the stage where we are today. Today we have Dr. Delaney Skerritt here today to talk around LGBT suicide deaths. And Delaney's going to be going through today a series of research that he has been involved with over several years, but actually he can probably describe it much more in depth than I can. What I'm going to do, I'm going to share Delaney's slides as a PDF in the chat box. It will come up there as a link in the chat box. Some of the slides have some tables with data and things on them that might be a bit hard to see on the screen. So I'm going to put that over there for people to download. And fortunately enough today, actually, Delaney is directly beside me, so it makes it really easy to hand over. So I've just shared the link there in the chat box, and I'm going to literally hand over to Delaney, who's right beside me.
Hello, everyone. So lucky, as Sally said, we're both here in Brisbane, so it makes technology a bit easier. Hang on, I've got this place. I'm more in the centre of the screen. Okay.
You're good to go.
Okay.
Yep.
So as Sally was saying, there are some slides there that have quite a bit of information on them. But as she said, she's also sharing those for you to be able to take a closer look. And the other thing is a lot of the research, or a lot of the findings that I'll be talking about today have been published in various journal articles, and I'll be showing you the citations for those journal articles. So please do try and, if you're wanting to be more familiar with the research, please try and access those articles and have a look at the in-depth discussion that's contained there. All right, so as Sally said, I'm talking around factors related to suicide death in LGBT people. The research did try and look at intersex as well, but wasn't able to actually gather any information on that. And so it's not an oversight that we've got LGBT as opposed to LGBTI. It's just the accurate description of what we were able to find out about in the research. And as it also says, we'll be talking around the implications for working with LGBTI around this issue as I'm moving through. And I should also say one thing there, what it says around suicide death, because it is actually talking about people that have died by suicide. And in that sense, it's really unique research, because it is, as it says on this slide, it is very hard to talk about, or to research, I should say, suicide death in people, because those people have passed away. Whereas in suicide research, there's often the distinction between non-fatal suicidal behaviours and fatal suicidal behaviours. So fatal being what we're looking at today, when people have died, and then the non-fatal being suicide attempts, thoughts around suicide and that kind of thing, which is obviously a lot easier to research. As I say, this research is actually about suicide death in LGBT people, and it's the first of its kind ever done in Australia. So that's it is really unique in that sense. And I'm really pleased to be able to share some of the findings with you. So that's one thing. That's around the type of behaviours that we're looking at here. And then the other, as I say on this slide here, is that as we know, people involved in this sector with community, it is difficult to put, and we don't want to put people into these boxes that claim to categorically describe who they are. And so it's always kind of rough and ready categories in that sense, but we have to work with what we can. But we know that we are working with people that are diverse in terms of gender and sexuality. But particularly when we look at older research, we can see that it was very difficult to find out any kind of meaningful information a lot of the time around LGBT people in the past, because of the stigma surrounding that. And so we found that in the past there really was a paucity of data, but luckily we are getting more data as we're moving forward with the research in this field. So just the general overview of what we're doing, what I'll be aiming to talk about today. I should also say I'm keeping an eye on the chat box there on the side. So if you do have questions as we're going along, I'm happy to address those as we go, or if you'd prefer to leave them until the end, we can do that as well. But if anything comes up and you're suddenly thinking, oh, what does that mean? Or could you just explain that a little bit better, then please just pop the question in the chat box. So the research that I'm talking about today, as I say, it's around fatal suicidal behaviours or suicide death in LGBT people in Australia. It's divided into two parts, and each part has been published in its own journal article, and I'll show you the citations for those, as I mentioned earlier. And also, as I said, talking about, whenever possible, implications for working with LGBT people. So the two parts are, the first one is looking at pathways to suicide in lesbian and gay people. So that's just lesbian and gay in that part. And then in the second part, looking at factors associated with suicide death in LGBT Australians in comparison with living LGBT people. So that will become clearer why it's split up that way when I go along. And I'd also like to wholeheartedly acknowledge the contribution to this research by the other members of the research team that I was involved in, who were the senior researchers on the project, who were Professor Diego Dallaire and Dr. Kari Kuldes, and the research was conducted together with them at ASRAP, or the Australian Institute for Suicide Research and Prevention at Griffith University, and funding for the project was received from Beyond Blue. As a little bit of a background, we as the team did a literature review on what was already known about suicidal behaviours in LGBT or LGBTI, actually, because there is a bit of research on intersex people in Australia. No research, as I say, prior to this project being done on any kind of fatal behaviours, but certainly on non-fatal suicidal behaviours, there was, a bit of research out there, not a great deal, but a bit, and enough for us to conclude when we did this literature review, which we published there, as you can see in the Journal of Homosexuality, that it's reasonable to consider that LGBT individuals as being more vulnerable to suicidal behaviours in the Australian context than their non-LGBT counterparts. Another bit of research that was published as part of this overall project, which I'm not talking about today, but it was there was one part which was done, and then there were interviews that were done which informed the research that I'll be talking about today. But prior to the interviews, there was a review done of the Queensland Suicide Register, which is a register of all suicide deaths that occur in Queensland. It doesn't systematically collect data on LGBT or LGBTI identification of individuals, but the data that were there for the period of 2000 to 2009 were reviewed and checked for any kind of mention that could be found of LGBTI identification. So over that 10-year period, there were almost 6,000 cases in the database, and the team was able to identify 35 just from information contained in each case that had some kind of LGBT identification, and then the factors or the kind of characteristics of those cases were compared with non-LGBT cases or cases that were in the database that didn't have any mention of LGBT identification. They were matched by other cases around age and identified gender, and then looked at to see how they were similar and how they were different. And so this was the very first study ever done on fatal suicidal behaviours, and one of the very first internationally in LGBT people. Just looking at some comments here, not to answer now, just a side note for your later consideration, please read using gender-bread person. Oh, okay, no problems. And transgender people may not identify themselves as trans. Yes, that's a very good point. So sorry if my language is a bit off occasionally. It is something that we do certainly need to be very mindful about, is the way that we talk about things. So when I'm saying transgender identified, I perhaps should say that transgender history might be more accurate in that case. What that particular bit of research found, as I said, and this is just background, so I won't be spending too much time on this, but it did show that factors related to LGBT people in the Australian context, well, that there were certainly some unique factors. So we could talk about a unique predictive profile there. One of the things I should mention when I'm talking about any factors today is that we can't talk about any kind of causal relationship between these factors and the death by suicide. They're just factors that were found to be related to in these cases. It's just because of the way that the research is conducted, we can't talk about causality as such. But there was a statistically significant higher incidence of relationship problems amongst LGBT people in this data set. Also higher incidence of depression mentioned in the case, treatment by ambulance at the scene, and then also higher incidence of HIV/AIDS. And then quite a few there that were quite near to statistical significance. With being just a small number of cases that were in this data set, it is obviously not always easy to reach the level, that level of statistical significance when we're dealing with smaller numbers, and a lower incidence of psychotic disorder. As I say, I don't want to spend too much time on this because there's a lot of information from the second two parts of the study that I want to spend more time on, but this was very interesting to see that we started to talk about a unique predictive profile there. What else did I want to mention there? Now, and the other important difference between this part of the research and the rest that I'll be talking about is this is the part that looked at differences between LGBT and non-LGBT people, whereas the rest of it looks either at lesbian gay people alone or comparing living LGBT people with those that have died. Let's see, yeah, I read that bit. Recent cases of blackmail here in ACT using apps that led to suicide. Okay, I wasn't aware of that. Thanks for sharing. Okay, so that's Very recent. Okay. Thank you. Maybe we can chat a bit more about that later. So this is the first part of the two parts where I'll be talking about the data from the second part of the study. So the first part, as I say, is looking at pathways, and it's just looking at lesbian and gay people. So both of these two parts of the research that I'm looking at used this so-called, or what's referred to, I should say, as a psychological autopsy approach or method. And what happens there, it's an in-depth interview with someone who knew someone that had died by suicide. And it's considered to be the gold standard in research around suicide death, because it's the way of being able to gather the kind of, I guess, richest level of data that we can around what was happening for those people in their lives. So in this case, it was specifically with LGBT, as I say, just LGBT. We weren't able to gather data on intersex people with this particular project. There were 27 interviews, and again, there's that word identity. Again, I'm sorry if that's not the most correct or accurate words we're using there. Again, like with the research that was done with the comparing those that had died that were LGBT with those that didn't have any mention of being LGBT in their case history in the Queensland Suicide Register, there was a matching going on. So here it was with the psychological autopsy interviews with people that knew someone that had died, and then there was 3 interviews done with living LGBT people per suicide case that were done, and those were matched with gender, with cisgendered people. They were all matched by age, plus or minus 2 years, and then in terms of transgender people, the control people who were interviewed were also either identified or had transgender history. So in terms of this first part, where we're looking at these pathways or life charts, we just looked at the lesbian and gay in that part, and then the bisexual and transgender are included in the second part. Just a couple of limitations which I'll mention at this point. We're dealing with quite a small sample here. It's 27 in terms of the actual people that died. In terms of the information that was gathered around the people that had died, it's looking back. So there's obviously, can be issues around recall bias there. And it's also an informant. It's someone else talking about the life of this person. So that can sometimes be a limitation in terms of reliability. For the people who participated as the control participants, so the living people that were interviewed, they were talking about their own lives. So there's that issue that we're comparing informant with self-report, which means that it's obviously a different approach. However, it was felt that we're getting better data by asking people about their own lives for the living controls, rather than asking someone else about them. Also, those controls were self-selected, convenient sample, which is the usual way of recruiting people in terms of LGBTI research, just because it is a small population and often around sensitive issues. So convenient sampling obviously is not what we'd prefer to have a randomized representative sample from the population, but that's not always possible, particularly for this kind of research. And of course, the other thing is we're talking about information that's gathered about people that were identified as LGBT. However, of course, we can know nothing about people who didn't identify or for living controls that aren't willing to talk about themselves within that community, or about the people that have died that weren't able to or weren't willing to talk about themselves as being part of this community. And so it's quite possible that those people have a different profile, there are different risk factors associated there. So just an overview of what's included in that PA or psychological autopsy. So there's demographic background, in this case, of course, issues around sexuality and gender, history of suicide attempts, exposure to suicidal behaviours in others. And so that's people that are known to the participants or to those that have died that engaged in suicidal behaviours. We looked at aggressive behaviours, history of physical and mental health problems, details of bullying and victimisation, a history of significant life events. So that can be things that have happened within the family, moves to a newer house or to overseas. We'll see those categories come up when we look at the life charts. Looking at the internalised shame scale, so the extent to which people were experiencing internalised shame, also internalised homo, bi and transphobia. The personality profile, the so-called Big Five personality factors that are looked at in psychology, social support scale, and details of hobbies and friendships, and also looking at mental health diagnoses with the mini International Psychiatric Interview. So this first half of the PA data were published in the Archives of Sexual Behaviour. There's the citation there, and it's using what's called life charts, and they've been used to map out pathways to suicide previously in the research, but this was the first application for lesbian and gay people. So life charts were plotted for each person, that an interview was done with someone that knew them, and then they were compared with each other and then categorized into sort of meaningful groups where they seem to fit together in particular important ways. So the initial kind of categorization that emerged was a younger and an older group, and particular factors associated with each of those groups. So the younger group, so it's not so much about the age, but it's about that everyone within that group, or most, as we'll see, had particular factors associated with them. So with the younger group, we've got 19 to 30 years old and 10 people there, and of the 10, 9 were experiencing non-acceptance around sexuality or gender issues. And then in the older group, ranging from 32 to 61, not 14 people there, but the majority of those, so 11 out of 14, were actually within a much narrower window, 37 to 43 years. And we can see there we've got 11 out of that group that had romantic relationship problems, and then 3 which also had the non-acceptance. And amongst the romantic relationship problems, we've also got a subgroup there that were living with HIV. So just going through those groups, we can see there with the younger group, and the bolded factors there show that the factors that were experienced by everyone within that group. So here we can see in the non-acceptance group, everyone were experiencing non-acceptance, and you can see that is very small. Is there any figure on my printout? Not so much. Okay. You can see the breakdown of where the non-acceptance was being experienced. So 8 with family, half of the family there you can see was with the father, and 4 from self as well. All experiencing suicidality in the period leading up to the suicide death, which may seem logical, but of course it's not always the case. In terms of and the other thing I should point out there is that 8 of the 9 also experiencing romantic relationship problems, which was the hallmark of the older group. But obviously what was the most characteristic factor here was the non-acceptance, but also romantic relationship problems being strongly present there. And so in terms of those mental health issues, we can see anxiety disorders in everyone, and also some kind of mood disorder experienced by all. So that's what a life chart looks like. It's a typical life chart, so it's not of any one particular person, but it just shows the general characteristics of what that group look like. So these are the life events that were investigated with the life event component of the PA interview that I was talking about earlier. So things like moods, forensics, so contact the law, physical and mental health are included there. And this particular one also includes issues around sexuality and gender. But as we can see in this group, we've got the non-acceptance being characteristic. And we've also got romantic relationship issues there, so romantic rejection. But you can see that how the life chart maps out what's happened for this person as they get closer to the death by suicide. And as you can see, in most cases, it tends to be an accumulation of events. So with the older group, we've got 14 there, as I say, having the romantic relationship issues. So 11 out of 11 here. The types of issues are broken down there. So we've got breakups, conflict, chronic loneliness. Also, characteristics. Oh, I'm sorry. Then I've broken it down into the two subgroups there. So, so just romantic relationship issues, and then romantic relationship with HIV. 4 with HIV, and then 7 without. All of those individuals, as you can see there, were experiencing work problems in the period prior to the death by suicide as well. You can see what the life chart looks like there. So romantic relationship and issues around work there as well. And this particular life chart shows issues around sexuality, gender acceptance there as well. Sorry, in this case, it won't be gender because we only included lesbian and gay in the life charts. And then there we can see what the life chart with the HIV would look like there as well. And then the other group was where there weren't issues around romantic relationships just prior to the death by suicide. But what we can see here is non-romantic relationship issues there in 3 of 3, and lifetime romantic relationship problems, but all dealing with issues of non-acceptance. If we look at the life chart, we've got the romantic relationship problems, but they're slightly further back. So just sort of to summarise what the main kind of findings or features are of being able to categorise what had happened by using the life charts is that, so first of all, we can see that they fell into younger and older groups, and the prime feature that characterised the younger group was non-acceptance by family, especially father, but also by self. Also romantic relationship problems for the younger group, mental health problems being prominent as well. Then the older group, particularly around that 40-year-old mark, primarily characterised by romantic relationship problems. Also work problems, as I mentioned, mental health problems there too. And then, of course, as we saw, the subgroup with HIV. So kind of a summary of a summary then is that we can talk about an accumulation of risk factors for those individuals here. Unique plus common, so unique in terms of things that were specifically related to being LG in this case, but also we can see common factors that are shared across findings from this type of research. So the issues are around having work problems, for example. So it's these LG specific factors that are very prominent for the individuals, and then accumulating with other factors that we often see in this type of research. And interestingly, in a recent Swiss study, non-acceptance and romantic relationship problems were listed in the top 3 so-called causes suicide attempts. So that's around non-fatal behaviours, but it's very interesting to see the parallels between that research and this. So implications, as I say, as I mentioned, that I'd be speaking about these as we go along. So clearly a need for inclusive approaches in mental health services to address these issues. But particularly what can be said about this is we certainly need relevant and accessible support around acceptance of self in young LG people, but also working towards and working with family, and especially fathers. And then, of course, the issues around the distress related to romantic relationship problems at all ages for LG people. And one of the things that I wanted to mention is that in work that I've done in collaboration with the QLife project, what is seen there in terms of the type of issues that people tend to bring up when they're accessing the QLife service are indeed these issues around coming out, acceptance of self, issues related to family, and also very much around romantic relationship problems. So that need is certainly emerging in other areas and being addressed by that extremely valuable service. And now moving on to the second part, and here we're looking at data that related to that whole set of PA interviews, so LG and B and T, and also here taking into account the research or the data that were gathered from the living comparison control participants. I'll just have a sip of my coffee. So as mentioned earlier, there were living control participants that were recruited from the LGBT community, and they were interviewed about their own lives using the same or an adapted version of that psychological autopsy interview. And here the idea is obviously to compare what might be similar and different between those who are living and those that have died by suicide. And there you can see the publication of that research in the journal Crisis. So I'll just go through different categories. I'll show you, which is going to be probably quite small, the tables listing results in more detail. It's not my aim to go through those bit by bit. There may be just some interesting things that we can point to there, but the data are certainly available in the published research. So general characteristics, and what I want to point out here is a kind of something that we need to be aware of, that it's important to remember that these kinds of findings may be related to the recruitment process. So the people that were, the living people that participated were self-selected, and the research was done at a university. So for example, we can see that the suicide cases were less likely to have a higher education, but again, that may be related to the types of participants that were involved as the living controls. And there was a marginally non-significant, so what I mean is almost significant, increased likelihood of being unemployed or on a pension in suicide cases. And there's nothing else I wanted to look at in those particular results there. So physical health, those that had died were more likely to be currently on medication than those that were interviewed as living controls. Suicide cases were more likely to be very or unsatisfied with their weight and appearance, and there was an almost significant increased incidence of chronic pain in those that had died by suicide. And you can see there's a lot of other things that were looked at in the study, but those are the ones that I talk about and have on those separate slides are the ones where there was statistically significant findings. Quite a few things emerged from the mental health side of things, and those that died by suicide were 23 times more likely using statistical tests. We can develop a use a type of test which says what the the odds ratio is with how much more likely something was to occur based on the data, and so clearly quite a strong result there, and quite statistically significant as well. So to have a current major depressive episode. There was also increased likelihood for anxiety disorders, so generalized anxiety disorder and PTSD in particular. Those that died were also more likely to have antisocial personality disorder and current psychotic disorder. Then issues around substance and alcohol use, so more likely to be substance users, using the DSM-5, so the current way that diagnosis occurs around substance use doesn't distinguish between dependence and abuse anymore, but this research was done using the DSM-4 criteria. So using that, there was increased incidence of substance and alcohol dependence as well as alcohol abuse in those that had died. More likely to be experiencing current suicidality, again, that makes sense, but it's still part of the findings. And also more likely to have made a previous attempt, which research shows that generally the strongest predictive factor around fatal suicidal behaviours is a suicide attempt, and more likely to be unable to work due to mental health issues. And as you can see, there were a lot of things looked at there, but the ones that I've mentioned are the ones that were statistically significant. And you can see if you take a closer look at the slide, you can see the odds ratios for, if you're wanting to see what the odds were based on the data. Contact with services. So suicide cases were more likely to have seen a psychiatrist at some point, and also more likely to have been a resident of a correctional or a mental health facility. That's the way that the psychological autopsy interview was set up, that it asked that as the one question. So it's not possible to say one or the other, correctional or mental health. It's just as one category. Violence-related factors and changes at work and school. So the significant findings didn't reveal anything related to changes at work and school, but they are included in the table on the next slide. That's why it's included in the heading here. But certainly around violence-related factors, there are significant issues that emerged there. So aggressive behaviours were more common in those that had died by suicide. There was more likely to have been a domestic violence order in place in those that had died by suicide. More likely to have been beaten so badly they had to see a doctor, and also more likely to have been sexually assaulted. Sexuality and gender-related factors. So the internalized homo bi transphobia was significantly higher in those that had died by suicide, on that scale 2.67 versus 2.23, and then an examination of the subscales within that particular part of the questionnaire revealed that there were significant differences on two of the subscales, leading to that overall significant difference. So the strongest one, as you can see there, was on the personal feeling about being LGBT, so 2.92 versus 1.78, but also a significant difference on the moral and religious attitudes towards being LGBT. Those that had died by suicide were also more likely to feel bad or very bad about their sexuality or gender, less likely to be accepted by fathers but also by mothers. A significant tendency for suicide cases to go through coming out milestones approximately 2 years earlier than those that were in the living control group. So first same-sex sexual experience, 16 versus 18.24 years old. First disclosure at 18.18 versus 20.69. And self-acceptance were applicable, of course, because that wasn't always the case, in 19.88 years versus 23.72, and those that were the living controls. Other psychological factors that were looked at, so internalized shame was significantly higher in those that had died by suicide. And looking at the personality profile using those big 5 personality factors, the two that emerged with significant differences between those that had died, and the living controls were higher neuroticism in those that had died and lower agreeableness. And that is consistent with general research that's done or has been done in around suicidal behaviours. So bringing all of that together, so compared to living LGBT Australians, those that have died, we can sort of summarise a lot of those factors into this experience of minority stress. So in the context of incomplete identity formation and an earlier commencement of that path to identity formation, and in what we could term as a more hostile environment, so being less likely to be self-accepting, or have accepting parents, having poorer self-esteem, self-image, and feeling bad, particularly around in terms of moral and religious attitudes about their sexuality. They experienced and participated in higher levels of violence, so there was more violence characterising those individuals that had died. Experiencing high levels of mental health disorders, as we saw, particularly depression, anxiety, and substance issues. And the personality profiles and contact with services are consistent, as I say, with general research done on that's not specific to LGBT people around suicide death. But we can see that, or we can say that issue around having more frequent contact with services points to missed opportunities for intervention, and we can use that in terms of speaking about implications. Which is that last point on this slide where it says that greater engagement for services while we have a greater engagement with services, we can still obviously increase that engagement, but what's particularly important there is about the accessibility and the welcoming nature of those services, that they are LGBTI inclusive, because we have that greater contact with services, but it's not addressing the needs, because that mainstream services may not be culturally inclusive. Just jumping back to the top of this slide, so need to continue working with LGBT individuals experiencing minority stress. So that's one of that main issue that has emerged there, particularly around looking at identity consolidation. So that issue of around internalized homophobia, biphobia, transphobia, internalized shame, working with those issues. As we saw in the pathways analysis, a specific need to focus on romantic relationship issues as well. And yes, that's all. So essentially, implications there, just really about it. Engagement with services and ensuring or working towards having services that are, or continuing work in that area where we have services like QLife, as I mentioned, that are culturally appropriate, and making sure that those services are available and accessible. Okay, so I'm going to jump over to a question, and so I'll just jump over. Thank you, slide, and there's my email address, so please feel free to contact me. I've got a question. I'm interested in finding around younger coming out disclosure and suicide. Do you have any theories around this finding? Oops, sorry if that just jumped around a bit. I kicked the table. Just that issue, the interpretation that I just made there, in that it has led to an incomplete identity formation in what seems to be a less accepting environment. So there's those issues around the internalized phobia due to the environment that this person is in, because we can see those moral and religious attitudes popping up there, less acceptance by parents. And so there's kind of almost like a precocious beginning, that it's done prematurely in a way when these people perhaps aren't prepared, but their environment isn't conducive to leading to a more complete formation of identity. It's really interesting, and it's really a fertile area for more research, because it's quite quite apparent and quite remarkable that there is that pattern of that earlier commencement of that so-called coming out process. Thanks, no worries. Hey, any more questions? It's really alarming given the rates of younger people coming out. Yeah, of course, any research around these issues is always really really powerful, really emotional, but at the same time, it's so valuable to know that the information that's coming out of this kind of research, and what it says is that, you know, the kinds of things that are being done, many of the kinds of things that have been done are really addressing these needs that are out there. But of course, you know, it also points to the types of things that can be expanded, that can be modified to be more culturally inclusive. I know there's a lot of information in there. Further education of clinicians are needed. Absolutely, yeah, exactly. Looking at these kinds of issues, knowing how the gender and sexuality issues are really quite central to what's happening here. And if that's not something that's on the radar of a clinician, they don't think to ask about those things. That, you know, particularly looking around those romantic relationship issues and how these people may not have support networks, you know, say within family, for example, that they can turn to. Framework appears to be adopted well to complex trauma interventions. It would be interesting to identify commonalities and differences between LGBTI services and complex trauma. Right, yeah. I guess there was a few things that jumped out in terms of the history of violence and that kind of thing. So that certainly points to that kind of thing, but also the trauma around the lack of acceptance. That really is something that definitely is an implication for practice. Curious about the issue of acceptance from family, and in particular parents. Curious about acceptance versus support. Parent can support, not necessarily accept. That's true. Yeah, that is it. Support versus acceptance. Unfortunately, the research didn't get into that nuance. It was more, it was really around looking at acceptance, or they can accept but not support. Yeah, that's a good point. But the interviews that were conducted for these were up to 3 hours long, so there was lots of data that's gathered in there. Relationship issues may be affected by discrimination, isolation, limited pool of potential partners, and possible impacts of all these things on partners. Absolutely, yeah, and I think that's the point I was trying to get at before in saying that that kind of less accepting environment, that there is an interplay between all these factors, so that if a person is experiencing romantic relationship problems on top of having a less accepting environment, the effect of that could of course be cumulative, and it really highlights the need for services for people LGBT according to this research, people of all ages that are experiencing romantic relationship problems, that there is somewhere to turn to during those times. And particularly LGBT in rural communities, absolutely, that's right. And that's why, you know, particularly the importance of online and telephone services for those people. So lots of great implications that you're helping identify.
Jump back on with you.
Yep.
I'm going to jump back on with Delaney here, and I really still invite people, if there's still some questions that you might be still typing, please feel free to put them out there. But I really want to thank Delaney for going through this research. I think earlier that there was one of the comments, but it really triggered the thought actually that there is still really a lack of adequate research around LGBT and I people who around suicidality, and these projects are one of the few that does exist. So in that, there's knowledge that it certainly doesn't capture the broad diversity and intersections of our community, but hopefully as a start to allow us to know where we need to explore more, and certainly investment in research in our community is really important to really understand the nuances in how when we look at suicide intervention responses, what we might need to do might be different to people who aren't LGBTI or to different communities. And I think this research has really, really highlighted those differences. And so hopefully we'll start to really inform our work and our practice, but certainly has really highlighted the need for us to explore this a lot more, and how often LGBT and I people are left out of research that looks at suicidality and risk of suicide. So yeah, just to thank Delaney once again. I find this really, I know research sometimes can be difficult, can be quite dry, all the statistics, but actually I've found this pool of research quite interesting, and really do think it will continue to inform our work. So today's webinar has been recorded and will be made available on the National LGBTI Health Alliance website in probably the next couple of days. And Delaney's email is up on the screen there. And I will once again just share the slides as a PDF link. So I've just shared a downloadable link. So for people who once again want to maybe have a closer look at some of those figures that might have been a bit difficult to see on screen, please feel free to download that. So there's this link in the chat box on your left-hand side. But I think that might have been the end of the questions. It was really great to have this conversation today. And please stay tuned for the next coming up Network Mind Out webinars. So thank you so much.
Oh. Thanks. Okay, good.